Thank you, Chairman, for your kind introduction. Good morning, ladies and gentlemen. Today, I will start my talk with tumor blood supply and liver microvasculature and tumor drainage. Based on tumor blood supply and liver hemodynamics, I'd like to explain the difference between basic concept of Deb-Tace and Deb-Tace. Then I will review the result of preclinical and clinical investigations. Let me start from tumor blood supply. In nodular encapsulated ACC, all the tumor blood supply almost exclusively comes from hepatic artery. So this type of ACC is the best candidate for chemoembolization. But in ACC with replacing or infiltrative tumor growth pattern, it is pretty hard to delineate the boundary of the tumor. Actually, in the border zone, there is a hepatic arterial supply and the portal venous supply is mixed up. How about in early HCC? In the developmental stage of ACC, we all know that there are considerable proportion of portal venous supply, such as early ACC and even in well-differentiated ACC. In addition to hepatic blood supply, larger tumors, especially in the subcapsular and exophytic growth, have higher chance of extrahepatic collateral supply. There are many sources of extrahepatic supply. So for complete chemoembolization, it is very important to find out extrahepatic collateral supply and treat these collaterals super selectively. How about blood supply in the normal liver? Normal liver receives dual blood supply from hepatic artery and portal vein. There are rich arterial-portal communications, especially through peribiliary plexus. So if you inject liquid embalming material such as Lipiodol, it can pass through the peribiliary plexus and enter into the portal veins. But in particulate embalming materials, it cannot pass through this peribiliary plexus. This slide shows the tumor drainage according to hepatocarcinogenesis step. In high-grade DN, the drainage vein is hepatic vein. But in advanced ACC, portal vein is the drainage vein. Based on all these facts, I prepared this schematic diagram explaining the blood supply of ACC. The encapsulated nodular ACC is exclusively supplied by hepatic artery, but the early ACC or infiltrating tumor have considerable portal venous. The blue color means the proportion supplied by portal vein. Using this schematic diagram, I'd like to explain the difference between Deb-Tace and Deb-Tace. Let me start from Deb-Tace. Actually, this slide, you saw this slide in the previous lecture by Dr. Polik. I have to declare that I have a good relationship with Jeff Gashwin in Johns Hopkins. So I gave him some slides to him. That's the reason why there is some overlap in the slides. Actually, Lipiodol is a liquid material, and it is mixed with water-soluble anti-cancer drug, mostly doxorubicin. Small amount of doxorubicin dissolved in contrast material, and the larger amount of Lipiodol is mixed by vigorous pumping. And you can create this kind of water in oil type immersion. containing doxorubicin carrying water droplets. A gel foam particle is the most commonly used embalming material. So what will happen if we inject Lipiodol into the hepatic artery? Initially, it fills the tumor vessels. If you continue to infuse Lipiodol, it fills the peripheral portal vein. At this stage, we embolize the tumor feeding artery using gelatin sponge particle. You can see the level of occlusion in gelatin sponge particles, embolization. This is a very ideal endpoint of Lipiodol chemoembolization. We can induce complete necrosis of tumor, but only in smaller tumors we can apply this technique. And another disadvantage is the Lipiodol penetrates all the microvasculature of the liver surrounding the tumor and even the liver capsule, so it causes some severe pain during the procedure. So it is extremely important to super select the tumor feeding artery using a microcaster. Once the microcaster successfully select the tumor feeding artery, we can apply that technique for complete necrosis of tumor. How about drug-eluting bead, Deb-Tace? Drug-eluting bead is basically a particulate embalming material which can load anti-cancer drug. This is the DC bead. Drug is loaded in the surface of the bead. This is the mechanism of drug loading. Positive charged anti-cancer drugs such as doxorubicin or irinotecan is loaded in the doxorubicin by ion exchange mechanism. And this is another drug-eluting bead, Hepasphere. What will happen if you inject drug-eluting bead into the tumor-feeding artery? The yellow color means the drug loaded in the surface of microspheres. The level of embolization is different. You can see the microsphere is much smaller in size and more calibrated, so it enters into the tumor vessels itself and then slowly release anti-cancer drug. But so the penetration into the surrounding tissue is not so deep, so procedure is very comfortable to the patient. But it cannot enter into the portal vein. So portal vein is patent. So the tumor supplied by portal vein can survive even after Deb-Tace. We can easily expect. Let me move on to result of preclinical investigation. The primary advantage of drug-eluting bead is less systemic release of anti-cancer drug and higher intratumoral concentration. It was demonstrated in the preclinical studies. And I'd like to introduce one very useful preclinical study. They evaluated pharmacokinetics and safety of drug-eluting beads in normal porcine liver. They divided the experimental animals in 3 groups. The first group is blend embolization using 100 and 300 micron size. Actually, this size is recommended in routine clinical practice for the best therapeutic outcome. So it's a very clinically relevant study. The second group is drug-loaded small-sized beads, and third group is the very big-sized drug-eluting bead. And they embolized the pretty large hepatic artery and totally occluded this one of large hepatic artery. And there was a pretty big difference in drug release profile. In large sized bead, drug release was very low. You can see doxorubicin plasma level is very low in large sized bead, but in small sized bead, pretty rapid illusion was discovered. And liver enzyme was also, as expected, markedly elevated in small-sized bead Deb-Tace. But in large-sized bead, the enzyme was not so much elevated. Macroscopic and histopathologic study also demonstrated severe portal tract injury and bile duct necrosis and hepatic infarction in small-sized Deb-Tace. But in large-sized Deb-Tace, the liver was not severely damaged. So, preclinical study, the lesson from preclinical study is non-selective, too aggressive embolization should be avoided to prevent bile duct and liver damage. If you embolize in clinical practice like this, in this patient, tumor is pretty small, and whole posterior segmental sectional branch was completely embolized, and the result was like this. The tumor was necrotized, but all the bile duct and liver was infarcted and atrophy during follow-up. This is the typical candidate of Deb-Tace. You can see hypervascular, multiple nodular tumors. One of them is exophytic in the bare area of the liver. So, exactly same with the lipoidal embolization. Deb-Tace also should be performed very super selectively. So, based on the tumor location and growth pattern, it is easily expected to be supplied by extrahepatic collateral. So we searched it and find out adrenal artery supplying this tumor, and we embolize these branches using drug-eluting bead and super selectively embolize all the tumors using one by one. And this is the final angiogram. Can you find out any difference between pre-embolization angio and post-embolization angio? Only the tumor feeding artery was effectively embolized. And this is the typical initial follow-up result. You can see complete total necrosis of the nodular HCC. But 3 months later, small recurrent tumor developed at the periphery of the tumor. We can easily expect. Actually, during follow-up, we can see considerable proportion of tumor patients have local recurrence. And at this time, the tumor was supplied by cystic artery, so we changed to the lipoidal and selective treated this feeding artery. And several months later, the tumor in the segment 7 also recurred, supplied by adrenal artery. These fine feeders can be more effectively managed by lipoidal. So after combining Deb-Tace and followed by lipoidal TACE, we could completely manage all these tumors. Clinical trials also demonstrated pharmacokinetic advantage of Deb-Tace. You can see dramatic difference in serum level of doxorubicin between Deb-Tace and conventional TACE. How about therapeutic outcome? Currently, until now, there are 2 RCTs available. In Asian countries, still there is no RCT. In precision trial, they evaluated tumor response at 6 months. The objective tumor response was about 13% better in Deb-Tace, but statistical significance was not reached. However, in subgroup analysis, they demonstrated significant advantage of Deb-Tace in child B, ECOG1, bilobar disease, and recurrent disease. In severe adverse event, alopecia was significantly higher in conventional TACE group. Other complications were quite similar. The toxicity is separately analyzed by another paper. Liver enzyme elevation was significantly higher in conventional TACE, but bilirubin level was the same. And in advanced disease like this, serious adverse event was significantly higher in conventional TACE. There's another RCT. It's a pretty small single center study. 67 patients randomized to 2 groups. Post-embolism syndrome was quite similar. Hospitalization period was about 1 day shorter in Deb-Tace, but 24-month survival was same. I could find 2 papers reporting 5-year survival after Deb-Tace. One from Greece by Dr. Malagari, and 5-year survival rate is 23%. One paper from Barcelona clinic, 5-year survival rate is 38%. This 5-year survival rate can be different depending on the baseline patient characteristics. Based on these preclinical and clinical trials, either practice guideline position Deb-Tace like this. The use of drug-eluting beads has shown similar response rate than conventional TACE associated with less systemic adverse events. So in summary, what are advantages of Deb-Tace? Less systemic toxicity, absent or mild pain during TACE, less post-embolism syndrome, shorter hospitalization period, and better standardization of procedure. Overall survival is quite similar, but hopefully there will be a subgroup with consistent and better therapeutic outcome. What are disadvantages? It's inconvenient to use because loading time is needed. It is not visible, so it is difficult to monitor successful delivery of to the tumor or inadvertent embolization to non-target vessels. In non-selective to aggressive embolization, biliary complication can develop. If non-target embolization can cause more severe complications than conventional TACE. So, further investigations are needed. Which subgroup benefits most with Deb-Tace? And what is best standardized protocol? Thank you for your attention.